Thank you for a very stimulating discussion about Medicaid. I think we'll go ahead and open the floor to questions. And I'll let Maxine let me know when she would like us to go to lunch. So we'll have questions until we have to go to lunch.
I guess I'll start then. Kathleen, one of the things that we have talked about in this 2 days are all the things we're learning about how we can improve the quality of the birth setting in right now based on what we know, and not only with the home births, which really represent a very small percentage, still the bulk is in the hospital. And I do believe Medicaid isn't getting its money's worth in medicalizing births. So based on, the data and the science, there are lots of things that we can do right now to really improve the outcome in hospital settings. So I'd like for you to address that possibility, because there are quality improvement measures that I think we can really do right now. We don't have to wait. We have a lot of information, and the science supports it.
I think that's great. I think that's exactly in alignment with where a lot of the conversations are going right now. And I think Will Schrank talked about that direction towards accountability, towards measuring the things we want to see, towards value-based purchasing. I think where that is the direction of the conversation, you have tremendous opportunity for resonance with Medicaid. That is what they are talking about in every quarter. Essentially, more than half of the people we cover are moms and kids, right? So we have a lot of interest in this issue. But I think that fitting into that dynamic of improving quality and improving value is the more appropriate conversation than, or the more salient conversation than one that is simply, there needs to be more home births. And I think that's the kind of thing that's going to have a lot more interest from Medicaid in the current environment.
I'm Pat Burkhart from New York State, licensed, the New York State Association of Licensed Midwives. I have a comment and a question. My comment has to do with the way our healthcare system is structured and the dominant role of physicians within that structure, be it in hospitals, be it in health insurance companies, be it in malpractice insurance companies, across the board, physicians dominate. And the AMA has clearly made it very clear that nobody is to support any non-physician provider in any way, shape, or form in the evolution of healthcare in the U.S. Bottom line message. So that I put out as something for everyone, particularly those of you in government agencies who are, whose job it is to help the system function better, to think beyond the realm of just physicians. Okay, question. How, in fact, do you resolve the inherent conflict of decreasing costs in a for-profit system? And this was really for Dr. Schrank, but I don't see him here. And so he left you all holding the bag.
I'm pretending to be Dr. Schrank. I have to wear glasses and get cuter. But I think that's a really good question. So let me actually start off with your comment, which is that one of the things that CMMI has been looking a lot at is the mid-level provider. And I think you really see that in the Strong Start initiative, is this real, that two of our models really focus on non-physician-based care, the birth center model and the centering pregnancy model. And certainly within the medical care home, midwives could be primary practitioners. That's up to the individual medical care home. And in our other initiatives, there's much more of a focus on, sort of what Dr. Bingham was talking about yesterday about having providers work up to their capacity. But I think you also have to keep in mind that because of the differential ways that Medicaid is reimbursed, that midwifery doesn't necessarily save money in the system, because some states do reimburse midwives at the same level as they do physicians. And of course, it does save money if the practice differential makes it so that, that the costs are lower. But and sometimes people do tend to put the cart before the horse, and they're just sort of looking at that level and not really thinking about the outcome measures. The for-profit system, all I can say is that Medicare has been shown to be one of the most successful programs in the history of this country as far as being economically more efficient than most deliveries, ways of that healthcare is delivered and providing results. This is not to say it's a perfect program, that, there couldn't be improvements made to it, but it's interesting that, in having a model of a program like that, that there's not a broader public embrace. So I don't really know how to answer your question, but I would just say that the
Medicare-
government is not really working against that sort of model.
Against the for-profit model?
No, it's not really working against the idea of having a not-for-profit model. I mean, they're the ones who run the Medicare program.
I understand that, but the system is basically for-profit no matter where you look, and it's a problem for us.
Well, I think I would just add to that. I think that there have been conversations, and I believe the National Governors Association, where I used to work, recently released a paper talking about taking a look at non-physician providers, and whether states were maximizing that area of their authority. And I think the bottom line is we know we don't do as much as we could. But I also think that the value conversation is exactly that conversation about, okay, for-profit, not-for-profit. The bottom line is, are we getting what we deserve out of the system? And not worrying as much about whether they're stakeholders or stockholders or not. But I do think that the value purchasing conversation is one that recognizes that the answer right now is no, and that the answer needs to be more often yes. And I think that that's the direction a lot of Medicaid and a lot of the folks at CMMI and others are taking to try to address that issue.
I'm Linda Cole. I'm the president of the American Association of Birth Centers. And I would just like to throw out a challenge to not only measure costs nationally, state level, and within these different models of care, to not only measure cost in billable charges and Medicaid reimbursement, et cetera, but to look at the actual cost of care at the point of patient care, because I think that's the way that you get to the really accurate measure of what it really does cost to deliver care. And I also would challenge everyone to take into account the cost to the patient from the patient perspective, from the societal perspective, not just the perspective of the government or healthcare organizations. So I wonder if any of you have also examined that.
I would say I think that getting to what things actually cost in hospitals has been something we've been challenged by. But I do think that there is an increased desire in that value purchasing conversation to actually understand costs. And there are a couple states, for example, that have tried to take a closer look at how this actually works. Excuse me. But to be honest, in Medicaid, we basically pay really low and assume the costs get shifted somewhere else. So we don't always like to look at that issue.
Hi, my name is Kate Ryan. I'm with the National Women's Health Network, and that's really funny because it's really true. So I have a couple of comments. So it was actually for Dr. Schrank. But I will, sorry, Caitlin, but I will try. So we, the National Women's Health Network also does generalized women's health. So we actually work on ACOs in the context of aging women's health. However, we've had a lot of questions we have a national membership from different states, including out west, where there are Medicaid CCOs or coordinated care organizations popping up trying to model themselves after these ACOs, looking at shared risks and shared savings and bundled payments. We see this as primarily as a good thing, the idea of bundled payments. That would be, there are a lot of issues with bundled payments trying to sort of address or realigns what we consider to be perverse financial incentives, fee-for-service moving to a fee-for-quality model. We think the triple aim could be really good if applied to birth and in the Medicaid program. But how to do that, tiering based on risk, seems to put that on the woman and the provider's call in a way that I'm sure will make everyone uncomfortable. So I'm curious if you've given a lot of thoughts to how you'll handle bundled payments to a birth setting. And then my sort of second question, thing we've come up against with ACOs that we see potentially being a problem for Medicaid, CCOs, or a Medicaid ACO model, since the ACA does allow for the secretary to apply ACOs to Medicaid without lawmaking through regulation. So is actually the increase in hospital mergers and hospitals that have a religious affiliation, and what that means in particular in the ACO model for end-of-life care and for Medicaid in terms of the whole range of women's reproductive health care. So whether and if and when she would like to give birth, if something happens in the context of her birth, and what that will mean for how much care and what care she is allowed to get according to, of course, I'm referring to the Catholic health directives. So that's a much more charged question, but one of great concern to us, because we do want to support this model, but that is a very serious concern. So they're my two questions.
I really wish Will hadn't left for those questions. You know, no, I mean, it's more that, you know, I'm heavily immersed in the Strong Start program, and I do some, I work on the Healthcare Innovation Awards and do some coordination with Partnership for Patients, because they're the ones where the Strong Start One initiative is, but I don't do very much with that whole bundled payment part. And the closest answer I can really give from, you know, the perspective that I do have is that we do already see some bundling of care within prenatal care, you know, as far as offering a package for all the prenatal care and birth delivery, you know, paid as one set fee. And from an evaluation perspective, it's a disaster. But you know, I don't really have any insight into what that does for the quality of care right now, especially since we haven't done our evaluation. But I'm sure Will, who's a really great guy, would respond if you emailed him directly. Okay.
I'll just add that, you know, I do know that there are some states taking up the bundled payment outside of managed care. I think in some ways managed care for this population is somewhat a bundled payment concept. But I think getting back to Maxine's point is we have a lot of opportunity here, and defining that scope and that approach that's going to work well. Maybe we'll find some ways that we can incorporate that into the ongoing initiatives in payment reform. And then, as I said, really try to share the best practices, because when somebody figures out how to measure this well and how to get the incentives aligned, we're all ears.
I'm Alice Bayless, a co-founder of Birth Care and Women's Health, newly retired a month ago. I just wanted to address a couple of issues. One is that we have our problems with trying to get adequate reimbursement from private payers. And one of our strategies was several years ago to audit the transfer data for our clients who were planning intended home births, which were about 60% of the practice then, and our birth center births, which were about 40% of the practice. So what we did, and this was prompted by one of our private payer insurance companies, when it was time for us to renegotiate our contract, they wanted to cut our fees. So our goal was to explain to them how much we had saved them. What we did was audit the EOBs that were sent to our clients who had transferred to the hospital. We figured that we had a 98% intention to treat clients who were multips remaining in the practice without a transfer. We calculated that about 68% of our primips remained with us either at home or in the birth center, and that 93% of our clients had vaginal births. So there was a whole pool of expenses that we audited from the EOBs from the clients who were transferred, and we figured out that we saved our little practice, saved that particular managed care organization $300,000 for the year that was in question. So if we could do that with the 3 midwives at the time that we had, that's $100,000 a midwife that was saved by the system. We owe a lot of our success, I think, to the excellent collaboration that we have originally with MDs who took our clients in the hospital. And now the practice also has relationships with hospital-based nurse midwives who can accept our clients, and generally it's the primip who needs a little Pitocin, maybe an epidural, to finish her job after a prolonged labor. Anyway, also we attribute that savings with excellent education that the clients are motivated themselves to get, and with centering pregnancy, that's an added asset. And even in a home birth practice, you can do something that is labeled group prenatal care by one of the practices over on the Maryland side, which really motivates clients to stay well, to be well. They can give each other all of that peer support to do that. We were able to save this money by reducing hospitalization costs, by eliminating or reducing anesthesiology help with epidurals, because the epidural rate obviously at home is nil, and focusing on non-pharmacologic pain relief. And our average APGAR scores were excellent. We did not bring, quote, train wrecks into the hospitals because we had that good relationship with our collaboration. So unfortunately, we were not able to provide Medicaid care to our clients because the application changed, and the language in the application said that we needed a supervising physician. And none of our doctors were able to provide that supervisory responsibility for the care that we provided. So I'm curious to know, is there an overarching federal application that eliminates the word supervision and rather talks about collaboration, consultation, and referral?
No, there's not a federal standard for that. It does vary pretty widely. To be frank, we've had a bit of a backslide on this issue with the way that the primary care payment increase to Medicare levels is implemented, that supervisory is a required context. So I'm a little concerned that states that wanted to maximize that, and the pressure to maximize that even from folks like nurse midwives and other practitioners at that level, might be to increase that word. So it is not a federal standard. It is not a requirement. It does vary by states, and it varies by their practice laws as well as by their Medicaid programs. So sometimes those two things are not necessarily aligned. Sometimes it may be that it's not required by the state's licensure to have that word, but the Medicaid program has chosen to do that. But the last thing you're opening up is a real challenge that I did not raise because I didn't want to get too weedy, but program integrity is the boogeyman of Medicaid. It is the thing that we fear the most, which is that we can have approval on the front end to implement something, and on the back end not get it paid for because program integrity rules won't let us do that. And program integrity rules are the rules by which we oversee the program and make sure that it's delivered by the people it's supposed to be delivered by in the right setting, et cetera. That is unfortunately where that word comes from. Supervised is a program integrity initiative, not one that's about the care decisions. So I don't have a good answer for that, but it is a real challenge.
My name is Elaine Germano, and I work for the American College of Nurse Midwives as the Senior Education Policy Advisor. And for Ms. Nolan, I wanted to clarify the slide that you showed about Medicaid reimbursement for midwives. There's a federal mandate that all states reimburse nurse midwives for Medicaid. So I think your slide, your map might have just been for all midwives, but for nurse midwives, it is mandated that all states reimburse nurse midwives by Medicaid. Now, whether or not they reimburse based on whether the birth occurs at home or birth center or hospital. But the other point I wanted to make was that 96% of midwifery births are in hospitals. And I wanted to follow up on Maxine's question about, you know, what are we doing with Medicaid payment incentives to maximize normal physiologic birth in hospitals, which use a lot fewer procedures and items. You know, I think about this slide I saw with a photo of a nurse in scrubs with all these tags, these price tags on her shoulder. Every time she hangs an IV bag, that's a charge. Every time she hangs Pitocin, that's a charge. Every time, you know, all of those charges that are decreased with midwifery care that tries to optimize normal physiologic birth. So how are we changing Medicaid payment incentives?
I just want to clarify something about Medicaid payment, which is Medicaid it's mandated to pay for midwifery care, and that would cover anybody who was licensed in their state, any midwife who was licensed in their state.
Oh, okay.
Okay.
Right,
Now,
so-
there are other restrictions, like with things like malpractice insurance connected to home birth and, you know, stuff like that, that may restrict the care that midwives are actually able to provide. But, you know, but that is the standard for Medicaid, is any licensed midwife.
Oh, good.
Right, yeah, and
Good,
I'm sorry if I
good,
confused
okay.
that, because it's really about whether they have that licensure category and what the limits might be within the state, and that's on their regulatory side, not necessarily in Medicaid. But I agree, if they have that category of providers, then they do have to reimburse them, because that's true of Medicaid. If you have a licensed provider, you have to reimburse them.
Okay, thanks. Thanks for that clarification.
Yeah, no problem. In terms of within the hospital environment and incentives, I think that's really the opportunity that Maxine is trying to promote, and one that I would, you know, like I said earlier when we were talking on this side of the room, the best practice is to do that. What does that look like? And I don't have a very good sense, and I'm not sure the Medicaid programs generally do. How do you leverage that? What are your opportunities? And I think that's really where some multi-payer initiatives that are really trying to drive this, because I think the one challenge we have is, and I mentioned Medicaid payments are not always, you know, as much as they could be. One of the problems we have is sometimes we can't always be the only lever. And when we're the only one trying to push it, and we are already not the best payer in that hospital system, we don't have a lot of interest from the hospital systems themselves to work with us. And so I really would encourage in that kind of setting, everybody needs to be delivering those messages. I'm sorry, portraying, passing along those messages to that hospital community to say, this is what we want to see. And when it's multi-payer, that's when you get movement, I think, at that level of practice, rather than with a very blunt instrument of Medicaid rates to hospitals doing this. We don't get into that kind of level a lot of times, so I think that's something to think about.
I just want to add to that where we have seen that kind of payment leverage happen, like Alabama, which reimburses the same amount for cesareans and for vaginal births, that did not cut their cesarean rate. So a lot of what's going on, you know, is not really all that much based on payment reform, but based on sort of standard practice and consumer demand and all kinds of other issues. Because the payment difference between something like with a cesarean versus a vaginal birth is so small anyway, and with the time saved for a doctor who can schedule something and do it in 40 minutes rather than sit all night with a laboring woman, you see those kinds of things driving the issue as much as actual dollars.
So we've reached our time limit for lunch, and I'm sorry to the people who still had questions that we won't be able to take them. But at this point, I think we'll convene and go to lunch.
Yes, and I'd like to encourage all of you to be back promptly at 1. We have one more panel, and then we're going to sort of tie things together toward the very end. Now, I just want to make a couple of announcements. I think the best thing to do for the guests is to go upstairs to the cafeteria, which is open today. And so there's very healthy choices and very quick. Members of the committee and guest panelists, you have your lunch in room 105. I just want to also announce, should anyone be leaving during the lunch hour, that these slides are going to be made available in another week on the NAS website. So they will be made available. And we will actually have a workshop summary sometime later in the summer. It will be available for people as well. So with that, we've had a very good morning. I'd like to thank both of the panels and look forward to seeing you promptly at 1 o'clock.